thank you. That was a real morale booster, that last sentence or two. I never had heard that before. And the reason I returned to Duke for 3 semesters was because I had lost an election, as a matter of fact. And so I was afraid I was an example of another sort, maybe, a warning sign. But I did enjoy that time back here for those three semesters, even though I had not sought the sabbatical. And I still maintain and value my ties to this institution. What brought our family to North Carolina in the early 70s was a job offer from Duke to help found what now is the Sanford School of Public Policy. We were breaking new ground, we thought, in lots of ways. My job was to figure out what the ethics course, the ethics program should look like in a graduate school of public policy. Interesting assignment that brought me into contact with a lot of medical school people, as well as law school, business school. We had a kind of professional ethics group that developed and swapped ideas. And of course, many health policy issues were in the mix then and now. And so the years at Duke certainly shaped my thinking in lots of ways, and the relationships are still very, very valuable. So I come back when I can, and I appreciate the invitation to be here today. And my assignment, as I understand it, is to reflect on health policy, and particularly domestic health policy challenges. And I picked up enough of the last discussion to know that that's not all you're talking about today. In fact, I'm well aware that many people in the room have made a marked contribution in global health, and that's also on your agenda. I do appreciate the contribution that this part of North Carolina makes to the overall global health scene in terms of research, in terms of organizations with like RTI and I won't name them all, FHI, all the ones that have that international reach and that do such good work overseas. And so there's a global health consortium that's been formed among these institutions here, and so we're quite consciously debating and discussing these issues and gathering strength, I would hope, for advocacy and for effective work. And here, too, we could talk about lots of present challenges. We seem to have escaped the draconian Trump budget, but I would say we're not there yet. We're not home free yet by any means. And I'll just say this in general about the budget situation. It applies to what I'm going to say about domestic health programs as well as research. That's, of course, another strength that is represented in this room. But the overall budget, which was so draconian and such a shock that the OMB director, who came straight out of the Tea Party, had such an impact, apparently, he and his thinking and the Heritage Foundation and the affiliated think tanks, that wing of American politics had such impact on the budget was really startling and striking. And that was nowhere more evident than in global health. 1/3 of a cut, we figured. And of course, it wasn't like global health was singled out any more than diplomacy in general. 1/3 of the State Department was cut as well, and $6 billion were taken out of the NIH budget, and on it went. So the Republican leadership of the Congress, now in charge in both the House and Senate, made a big thing of getting past the Trump budget, which is a good thing. But I would say that the extent to which those earlier shocking numbers were transcended is pretty mixed from area to area. A related area here in the Triangle that we're very sensitive to, and of course anybody should be sensitive to it, is the work of the Environmental Protection Agency, including a lot of health-related work that in IEHS, the only one of the institutes here outside of Bethesda, Maryland, the Institute of Environmental Health Sciences, the research program of EPA itself. That isn't a whole lot better in the Republican budget than it was in the Trump budget. And so that and many other things are going to depend on the kind of resolution that we get here at the end of the year. And I assume you know the broad outlines of that, but I'll just say that we have only a temporary reprieve. The fiscal year has started, in case you didn't notice, and we didn't have a budget, in case you didn't notice. So that's what's new about that, you say. We seem to go through this every year, and actually about the best I can hope for this year is that we have a resolution much like we've had each of the last 4 years. But with a different president and a different set of, a different kind of environment we're working in, that's uncertain. It's uncertain to say the least. When I see what is going on in terms of not just the budget crunch and the prospect of the lights getting turned out on December 9th, when you think that other issues have been dumped onto the Congress, a Congress that can barely function as it is, the Iran nuclear agreement is now in our lap. The Dreamers, that acute immigration challenge with respect to a particularly vulnerable set of young people, that's in our lap. And then something we'll talk about later, the Affordable Care Act subsidies are in our lap. That in addition to the challenge of just passing a budget and keeping government running for another year. So you see why I say in this environment it would be a very positive thing if we had a budget agreement on the model of the last 4 years. What does a budget agreement consist of? It consists of a bipartisan agreement to get the overall budget numbers off of the floor. I mean, the budget that the appropriations bills that the Republicans passed on their side alone this summer, which they, bragged about as transcending the Trump budget, the level they were marked up to would tell you why they weren't able to transcend it all that effectively, because the overall aggregate levels are sequestration minus $5 billion, as if sequestration wasn't bad enough. Take another $5 billion off on the domestic side of the budget, and there you have a bunch of bills that certainly I can't ask my members to support. In the subcommittee I try to have some leadership in, the transportation and housing area. Even more is that true of labor, HHS, education, the bill in which many of the programs you're concerned about would be located. You simply can't write a bill to those numbers. And so here's what might happen. This is what happened 4 years running, so maybe it'll happen again. The Tea Party wing of the Republican Party will not vote for anything, and therefore their votes can't be counted on to see this process through. And then, of course, there is the 60-vote requirement in the Senate, which also they can't meet on their side of the aisle alone. So the Republican leadership may come to the Democrats and say, let's do a deal. And the premises of the deal will be a couple of things. One will be that we do have to get the aggregate numbers off of the sequestration level, enough so that we can adequately address a range of needs and programs. And then secondly, the ideological riders have to come out, or at least most of them. And if we're willing to do that, I can tell you the transportation housing bill, give me 30 minutes, I can write it. It's right there. So is labor, HHS. So are all of them. The framework is there. The question is, do you get the budget deal that lets you revisit what was done this summer by the Republican side alone and get the numbers where they need to be? I'm hopeful that we can do that. I would never, ever claim too much for that. I mean, it's not a very good way to govern, not only doing it 2 months into the fiscal year, but doing a kind of maintenance of effort budget. But given the alternatives, I think that would be a victory in this environment. So for global health, and those of you concerned about foreign aid and the global health aspect of that, those of you concerned about research, not just NIH, but the kind of basic research at NSF, the related research at CDC, other research agencies, and for those concerned about the flow of funds for other health programs, including the Affordable Care Act and the kind of the degree of dependence we have there on appropriated bills, appropriated amounts, then all of this is tied up in the situation I'm describing. So we will work toward that kind of outcome, and if we don't get this, then the alternatives, as I said, are worse. We could have a year-long continuing resolution, which is, again, it's not the worst outcome because at least the funding levels are what they've been, but it is distinctly a defective solution. It kind of bespeaks the failure of the process. Or then you could revert to something much more drastic in the way of overall cuts, and we go downhill from there. So a lot's riding on our ability this fall to get at least the budget act together. And as I say, that's been greatly complicated by a lot of items that have been loaded onto the Congress by recent actions of the president. All right, just in talking today, and I know we want to leave time for discussion. I certainly want to do that. Don't want to lecture at you too much. But I've been asked to speak to the domestic side of the overall issue, and I'm happy to do that. And I'll start with the Affordable Care Act, as you might expect me to. This law has had, on the whole, a significant impact on our state and across the country. It was itself a political compromise, although some on the other side described it as Soviet-style health care. Basically, it was an attempt to use market mechanisms to deliver health care to that segment of the population that was not otherwise covered. In other words, the premise was leave workplace-based coverage in place, leave the various public programs in place, expand one of those significantly, Medicaid, and then facilitate a marketplace for those who are not otherwise covered. And that was considerably dependent or derivative in terms of what Republicans had suggested in the past. But you would have never known it. This became a highly partisan, highly polarized issue, as all of you know. It has had its shortcomings and its flaws. Plenty that I and probably you each could suggest that would make this better, make it work more effectively. But the law is working. Something like 500,000 North Carolinians who didn't have insurance before now have it through the Affordable Care Act exchanges. Nearly 1 million seniors in our state have received the preventive care services, which the Affordable Care Act instituted. And 70,000 young North Carolinians have been able to stay on their parents' insurance plan until their mid-20s. Now, our state shamefully did not expand Medicaid as the Affordable Care Act permitted or facilitated, and so another 500,000 people who could have had coverage don't have it because of that ill-advised decision by our state leadership. Look at everybody's coverage, the kind of junk insurance that was actually fairly prevalent, the kind of standards or lack of standards in insurance policies that led people to think they had coverage when they really didn't have so much coverage. Those things have also been addressed, so insurance discrimination and bare bones coverage, all these things which I would assume we don't want to go back to, they have been addressed and corrected under the Affordable Care Act. including the notion that being a woman was a pre-existing condition. As you might remember, back in the bad old days, women paid a lot more on the average for insurance than men did, and there was nothing standing in the way of that. So, well, and one other thing needs to be said, I suppose. That is that with plenty of challenges, the Affordable Care Act has begun to settle in. Ironically, just as the upheaval is threatened. Blue Cross Blue Shield tells us that for the first time in this state, they're actually making money on ACA plans, and that if the market were stabilized, their increase for next year, their premium increase for next year, would be exactly zero. Now, you may have read in the paper that their premium increase for next year, in fact, is not zero. It's more like, what is it, 17, 18% on the average? Why is that? Because this is a very uncertain, unstable market, and that's because of the administration's desire to make it that way. But this is working. This is working in most parts of the country, and I would think we'd get about 75, 80% support in the American public if the Lamar Alexander, Patty Murray plan to stabilize this marketplace, these near-term measures that would simply keep the subsidies flowing, would stabilize the marketplace, and maybe live to fight another day on some of these other issues. I think people would overwhelmingly welcome that. And if we were to be able to do that, and you're following the news day to day as to whether that has even a remote possibility of happening, if we were to do that, I believe we would see the Affordable Care Act marketplaces stabilize further, settle in further, and we might be amazed how well it would work. But of course, that's not the program on the side of the majority or the president, and we've had these successive efforts to repeal the Affordable Care Act, and I won't go into that except to say they haven't succeeded. But at the same time, we're left with a good deal of uncertainty as to what their intent is, much less what the ultimate result will be. The administration's administration of the act, to put it mildly, has not been helpful. The latest move, and the most destructive move, and the one that actually has a kind of make or break potential, I think, is the end to the funding for the cost-sharing reductions that allow insurers to provide low-income enrollees with lower costs. That is an absolutely critical linchpin. And if that's pulled out, then, and of course that's what Alexander and Murray are addressing, that is the centerpiece of their proposal, that you would leave that in, you would appropriate funds to achieve that, and then you would work from there to see what else stabilizing the market requires, such as stop-loss provisions for carriers and other provisions. But anyway, the subsidies have been pulled back. Other things have happened that aren't helpful, like cutting the enrollment period in half, like slashing the advertising and outreach and navigator funding for this next year, and so on. I think it does amount to sabotage. And the question is, can we, from the congressional side now, require something other than that? And if an effort does move forward, a bipartisan effort does move forward, will the president be the least bit helpful in getting it enacted? The benefits to women, I assume you're well aware of. The essential health benefits in many ways do address women's health in particular. Although a few men have raised the issue, why should I be paying for maternity care? I think most of us know how essential health benefits works and how insurance standards work. And you understand that maternity and newborn care, preventive care, including mammograms, cervical cancer screenings, birth control, access to free or low-cost breast pumps, those are not frills, those are not luxury items, those are quite basic. And there's some, by the way, that apply particularly to men. But what's going to happen to those? and what happens under repeal. It's open season on that very notion of minimum standards, minimum requirements for health insurance in or out of the ACA. While we're on the subject of women's health, you know that it's not an exaggeration to say that these criticisms of the Affordable Care Act in terms of women's health are not isolated. There's a range of other measures that particularly have effect on women. This executive order restricting women's access to birth control, and also removing the requirement that birth control be included from the ACA policies. This is really, I'd say, extreme. It's not. We're accustomed to debating abortion in this country. We're not particularly accustomed to debating birth control, contraception. But yet we have this, under the guise of religious liberty, this proposition now that an employer who doesn't happen to approve of contraception can in fact keep that off of the insurance policies that his or her employees that his company or their company finances. There's been an expansion under this administration of the global gag rule, which has to do with the funding of Planned Parenthood, other organizations that have abortion services in their portfolio, but the vast majority of their services have to do with women's health more broadly. The U.S. funding for the UN Population Fund under related set of accusations and charges. This stuff's been around forever. It's just fluctuated in a very damaging way through Democratic and Republican administrations for as long as I've been around, and probably before that. They've allowed the state to withhold Title X family planning program funds from clinics that have abortion services among their services. They've defunded, of course, voted to defund Planned Parenthood repeatedly, and that's a feature, by the way, of the budgets that passed this summer. You know about the two interim final rules on birth control and what that would do with respect to the ACA policies in particular. So, you could probably tell me more than I can tell you about the isolation of contraception from other health care benefits. Of course, it's clearly discriminatory. But there's just so much ignorance that seems to be embedded in that sort of notion that contraception doesn't belong in a basic health package, and there are myths that have been perpetrated about birth control which creep into this debate. And then, ironically, they say, well, this is really not going to affect all that many women, because they have contraceptive coverage in Medicaid, but then look over and see what they're doing on Medicaid, and there's not much comfort to be had in that assurance. So, birth control is health care, pure and simple, and it's really past time for our elected leaders to understand that basic concept. We can talk, if you want, about advocacy and about the kind of range of groups that are working on these issues, and that I'm sure many of you are helping with. We do have a pro-choice caucus that Diana DeGette and Louise Slaughter chair. They still do a good job. It is a minority of the Congress, but still there's some good work and good advocacy going on there. We have of course, candidates all over the country who are running for office, and often these healthcare issues figure prominently in their campaigns. Again, you're probably aware of that and helping sympathetic aspirants or incumbents, one would hope. But here too, we have a lot of barriers, and I'll just give a plug for a comprehensive bill that Tom Udall, Senator Udall, and I have introduced called the We the People Act, which addresses some of those barriers provided by huge mega donors, by not just special interest groups, but unaccountable special interest groups, groups that have enormous resources and because of some flawed Supreme Court decisions have very few restraints on what they raise, what they spend, or even telling us who they are, accounting for the money they spend. So there's a large reform agenda that I think is related in a positive way to healthcare politics as well as to other issues that we need to focus on. So we get lots of effective advocacy. I think a disturbing number of members of Congress, I'd be interested in your experience on this. I have more and more groups come into my office and say, you're the first member we've been able to see all day. I don't know if you've had that experience. But I think to the extent members are in gerrymandered bubbles of districts, and to the extent this theory takes hold that, well, we just cultivate our base, we just stoke up our base, and that's really the way politics works, that means they're not going to talk to you if they don't agree with you already, or if you make them the least bit uncomfortable. That's never the view of representation that I've had, nor is it a view that I think you should allow anybody to have. People should just be aggravated to death until they give you a hearing and until they understand that it's their obligation, whether they agree or not, to, especially with constituents, to understand where the concerns are, what the needs are, and to give you some kind of answer, even though it may not be in an entirely comfortable exchange. So whatever you want to talk about, I've gone on too long already. But any of the policy and funding issues here that you'd want me to get into, or I'll do the best I can with it. Or if there's anything in the way of just practical concerns about advocacy, I'm told we might want to address those too. So I'm at your disposal. Thank you so much. It's great to be here.
Hi, Representative Price. Thank you so much for coming, and thank you for your many years of service.
Sure.
You've really been quite an inspiration to many of us, so thank you for that. I'm wondering, after the election, I think a lot of us were fired up and calling your offices every day, calling all the offices every day, and not getting responses from some of our representatives. I think a lot of us now feel a little disheartened and don't really know where we can plug in. So from your view from Washington, what do you think we can do just as ordinary citizens to make the positive change that we would like to see?
It's a very common question, and if I had a simple silver bullet type answer, I would give it, I promise. But I really do think the question is one that people have to answer in their own ways, depending on where they're situated and what kind of leverage, what kind of resources they have. I've already indicated that I think concerned citizens, usually in groups or small groups, coming to members' offices, being very, very insistent and articulate about your own stake in policy, your own role, whether you're a provider or a recipient of health care. Or, of course, all of us are recipients. Everybody is an expert on healthcare. That's one reason the issue is so fraught, because everybody has something to say and think about it. That kind of insistence that representatives, you don't have to go to Washington. In fact, I'd recommend against going to Washington. Just be on the doorstep here of members' offices. And in North Carolina, we always have to tell the groups, don't just preach to the choir. Don't just go to the offices that you're familiar with or are in the metropolitan areas. Activate your network wherever it is, and hopefully it's out in Hickory or in Clinton or in Murphy, North Carolina. And those are the people who really need to hear from their constituents, and to the extent you can activate that and make it happen, either on state or federal issues. That's a great thing. I think the healthcare area is one where associations, professional groups, patient groups. I mean, the array of people who have something to say and who have a stake in these policies. We're talking very broadly now. The whole range of things you're talking about today. Those are it's a really potentially effective array, I think, of people and groups who you need to activate. Tracy Lovett, by the way, is with me, who runs our Durham Chapel Hill office here, and so she's heard me tell this story, but I'll tell it again about cancer research and about the 4 cancer centers in North Carolina. They, of course, do wonderful work. One of them is right here. One's 8 miles down the road. They would always come to Washington with their white coats on, and they would tell us about exciting breakthroughs in cancer research. And of course, it was exciting and it was inspiring. But I tell you, they changed their tactics one year, and nobody who was around will ever forget it. One year, they asked us to organize a delegation luncheon with the whole North Carolina delegation, and they brought their patients. Totally different experience. As one patient after the other got up and testified as to the effects of the kind of research and treatment they had gotten, their hopes, their fears, their aspirations. It was very moving. And I really respect the Juvenile Diabetes Organization does this. I mean, there are groups that are really good at this. Multiple sclerosis, ALS. There are groups that have picked up on this, and they're very good. And I admire tremendously the patients who will come up to Washington, often at great personal difficulty and certainly at some level of stress, come up and tell their story for the sake of the cause. And so that's the best answer I can give you is just think about the strengths and possibilities that you have, you and your colleagues and your organizations. Think about that hard, but certainly understand that your good works do not speak for themselves. You never should assume that. You could be doing the most wonderful, life-saving, life-enhancing work in the world, but you got to tell about it. You got to brag about it. You got to insist that it's worthy of support, and in this case, public support. So please do think about that. But I can't give you a simple answer as to one tactic or two that always work. You just have to be creative, and more people are they're on our doorstep. I'll tell you that, and they are increasingly good at the business of persuasion.
Yeah, hi, Congressman. Thank you so much for taking the time to be with us today and for your work in Congress. My name is Melissa Watt. I'm faculty in the Duke Global Health Institute.
No.
And when the repeal of the ACA, the bill was being drafted, there was a picture that circulated on the internet of discussions about what would go into that bill. And I think there were 40 plus men in the room and no women. And we know that there are less than 20% of Congress is made of women. And I wonder if you could speak to that and how that the women's absence in decision making and policy making impacts the conversation, the lived experiences that are brought to the table, and what can be done to advocate for and support more women in elected offices and in positions of leadership.
Mm-hmm. Well, you're exactly right, of course, that the gender mix in our institution, or I would assume in most organizations, has a big effect on the tenor of the discussion, on the topics chosen for discussion, on the kind of weight given various approaches and issues. Having said that, there's certainly some women on the other side. There's certainly some women on the other side, and some of them are very insistent on their viewpoint. And So there needs to be, I would say, a lot of grassroots work done, especially with young women coming on about these issues and about politics in general. And but because when you get right down to it, the kind of view people have of government's role and of accountability and all these kind of concepts that define a responsive government, and whether you're going to succeed at persuading that government. A lot of these have to do with attitudes that are instilled very, very early in girls as well as boys. And if you've had 2 generations now of being told government is the problem, without a more subtle sense, let's say, of how in a democracy, government should be an instrument of our common purpose. If you come at this with ideological blinders, then educating you about healthcare isn't necessarily going to do the trick in terms of the way elected officials conduct themselves, or the way advocates, how effectively advocates can be marshaled. So that's one thing. Yeah, it's not totally gender-based, and it's also true that the women who are active in this area, Diana DeGette, for example, a good friend of mine. I mean, she's worth about 3 or 4 members. She's very, very good, and the women who are champions in these health areas are a very impressive group. But there need to be more of them, and women and men in the Congress need to hear from you. They need to be armed with advocacy, with information, with the makings of effective advocacy, and also given encouragement. But your basic premise: more women would help. More women who are sensitive to these issues would help. Absolutely true. All right. Thank you. Thanks. It's great to be with you.